Okay, we have about 15 minutes for questions. If you could state your name and affiliation before asking a question, we'd appreciate that. Yes.
Lisa Culver from the American Physical Therapy Association. I have a question for the first speaker and a comment for the third. When you had talked about the changes in season and that was something that should be considered, is that something you've actually planned or put into your intervention in any calculated way to see how effective that is and how to do it?
Well, when I first noticed that in the Dr. Lou Keller study. So when we were doing this, we were recruiting and the interventions were going on at different times, and there's that delayed group thing. So we knew we would be able to look at it and capture it. Yeah, obviously this isn't a big deal. I actually looked at it in a study years and years ago, and it's not a deal in Hawaii. Right. As you could imagine, so I guess the take-home message is do your studies in Hawaii, but if you do them in Pittsburgh.
Well, it's a great observation, and I think it just goes along with lifestyle study and behavior change. You need to know what variables are keeping the individual from being active or changing the way they eat. And,
well, let me just say, it's an important issue, not even in just assessing, but it's also important when you're trying to do intervention.
Correct. Yes. Yeah. Absolutely. And then just a comment and perspective with the last, in talking about obesity and how it becomes a factor in and of itself. And I think the one thing that we haven't talked about today, but you kind of directly alluded to, is that obesity itself is a physical disability and can be. And so recognize that in itself that can prevent you from being active and quality of life, et cetera. So just great observation, and I think it's something to be importantly aware of.
Yeah, thanks. I agree with you that it has some limitations, and one thing that has hit home to me, and I had early in my career spent some time in a physical therapy setting, was that people presented themselves with back pain, and everybody gave them this TENS unit and did this and did that and everything else. But it was pretty clear that these people were carrying a significant amount of body weight, and in that physical therapy setting, nothing was done to actually address that issue, when in fact that was probably contributing to some of that back pain that people were feeling. So I think we need to be thinking cross-disciplinary in terms of these types of things in order to have the biggest effect.
Yeah, and to follow up on that, I totally agree, and I don't know how long ago that was, but part of it's an issue of reimbursement. It's very sad to say, but it is. But I think in terms of osteoarthritis, PTs would obviously be thinking about it. And more we're very much aware that there are some cases where that is an issue that needs to be handled by somebody else. In some cases it might be us, because we're talking about abnormal weighting on joints, maybe need for equipment temporarily, a variety of things. But you're right, and we're trying to get better at that.
Abby King, Stanford University. Thanks for some excellent talks. I really enjoyed this session. So Gabe had opened the door when he mentioned weight cycling, and I was wondering if John and Andrea could comment on that and what you see from your own data sets in terms of the prediction in terms of weight cycling and what it forebodes for weight loss in the future, weight maintenance, weight regain.
After you.
After me, let me take a crack at that. No, I still think that weight cycling 20 years ago was a big deal, and kind of people stopped talking about it, but it's a huge deal. And are there detrimental health benefits of it? I think that we can continue to kind of keep fighting about that and trying to figure that out. It's hard to do randomized trials of weight cycling, but it's a big issue, I think, on a number of factors, and we've published a few papers that it's people respond psychologically when they start to regain weight. Things start to deteriorate for them, and then that just kind of creates a vicious cycle of them starting to become less adherent and so on and so forth. And that's why I think that we have to figure out, how do we send this message to the public and understand that when people, I've done this, I've done trials where I've said, I just want to recruit people who are overweight or obese to an exercise-only trial or a weight loss trial. And I've had such difficulty recruiting them to an exercise-only trial, but I have to turn them away for a weight loss trial. But we also then have to figure out, how do we keep the weight off? We don't want a person losing 100 pounds because they lost 10 pounds 10 times with us. We want them losing 100 pounds because they lost it once and kept it off, right? And I think I think we are now starting to see interventions that are working long term. And now the question isn't, in my mind, what's the dose that people need? The real question for me is, how do we put better behavioral programs in place to get more people to adopt the things that we know are now working? And I think that's where the action really should be. And I think that understanding when people are starting to slip, too many times, in our trials, and I think it's the detriment of the randomized clinical trial. I know that's, too many times it's like, well, we'll measure them here, we'll measure them here, we'll measure them here, and there's nothing we can do along the way. Now, these adaptive trials give us a new opportunity to say, when somebody's starting to kind of slip or fall off the wagon, we have an opportunity to systematically change that, to try to hold them back. I think this is a golden opportunity for us to try to improve those long-term outcomes and prevent those big swings. We're always going to have swings, but we want to prevent the big excursions from that weight.
Yeah, I was just going to add, so in the DPP, which is the one I could really speak to the longest, so we actually had help and boost sessions for everyone during the actual DPP. So during the DPP, everyone in the lifestyle met. Pretty much every month would be in contact with them after the initial core. In the DPPOS, we had 4 sessions a year for everybody, and then 2 extra for the lifestyle group. And so our participants would come, and they may be slipping on their weight, they may be slipping on their activity, and so we would just help them through whatever. And then I think the theme all throughout is, when they fail, we teach them tips on how to get past that and the behavioral part of slippage. But we didn't, so our big thing is, when they start slipping, we help them figure out what they need to do. Life happens, things change, and then often they have to change their mantra to work through that slippage.
So one more very quick comment, and hit me after I got done. We just finished a trial's coming out. It'll be published in MSSE. It's probably available online, where we actually proactively looked at our data and said, when do people tend to slip with their activity in a weight loss program? And we proactively put stuff in at those key times, and in 18 months, that group sustained a 10% weight loss compared to everybody else regaining. So these proactive ways of targeting when to do things are really important as well.
Aviva?
Aviva Muss, Tufts University. Andrea, I may have not seen this because the slide went by fast, but in the DPPOS, it looked to me like your worksite group fared less well at 12 months. And this morning, Jim Hill suggested that we should all have 30 minutes of physical activity every day at work. So I'm wondering, sort of from process evaluation, if there was something about the rollout in work sites that we should understand.
That's the group, so in our community program, not the DPP.
Yes. Oh, sorry.
No. So in our community program, the work site did wonderfully, but did not do as well. And I think a part of that is they were also younger and employed. So in the DPP, we found that our oldest group did better, and we feel that that's because a lot of them were retired and older and could put the time into it. So I think that's the same sort of thing. In our work site program, one of the things I didn't want to get into is, we also had a DVD. So in that work site we had, and that's why we picked that work site, they were always being sent overseas. And how do you do a community intervention in that respect? Well, they would do the DVD, and they would get a contact by the coach via email if it's too far away and we couldn't afford the call, or by phone, and that seemed to work well. But in answer to your question, I think it's a lot of age and retirement.
Russ, I'm going to ask one, and then I'll let you close it out, because we probably have time for 2 more.
Sure.
I think messaging is vitally important here. And John, during some of the stuff that you presented, it appears as though that the health outcome that is desired really kind of depends, is influenced quite a bit with physical activity sometimes being the more important driver of that outcome versus weight loss being the more important driver of that outcome. How do we take that information and present it and package it in a clear and concise manner for both the clinician and the patient?
$10 billion question, right? Just real quick, I think across the board, many of these individuals that we've worked with have multiple risk factors. So it's rare that you see someone with diabetes that may not also have a hypertension issue or something like that. So I think we have to play that common, the kind of common denominator. And I think that what we really need to do, is if we're going to address obesity and encourage weight loss, what we need is to make sure physical activity and the right dose of that and the right education and behavior around that is part of that discussion. That the first thing that they don't do is come in and say, just change your diet. And, no disrespect to everyone else, but the vast majority of people who deliver weight management programs are not people who know exercise very well. So we need to be part of that team in that discussion and make it a high priority. And we also, though, have to make sure the physicians don't just say, well, just go out and do some physical activity and everything's going to be okay, because that may not be the right message, either. So I think we have some work to do here for sure.
Russ?
So for Andrea, I was struck by the fact that you referred to DPP as an efficacy trial. And my issue is not the semantics, it's really the translation of it and what's realistic. So I certainly understand that DPP was well-funded. It was a huge study, probably had more resources to implement the lifestyle intervention than might typically be the case in a large-scale study. But is it not true that in the economic analysis, the lifestyle intervention was not more expensive than the metformin arm? Is that true or not true?
Cost stuff. So in the regular DPP, the most economic was the it's on. Oh, sorry. In the DPP, metformin was the most economic. I think you gained. I mean, it was cost savings. Thank you. And in the lifestyle, it was cost. What do you call it? Effective.
So I guess my question is, should we consider an intense lifestyle intervention such as was implemented in DPP as not realistic in day-to-day practice in our communities, or do you think it could be?
Well, I mean, but that's all the community stuff we're doing was based on the DPP. That's DPP-based intervention, and we're actually working on the cost stuff now, so I can't throw any numbers out, but it's basically having a trained coach, and the materials are free, and having a room to hold it. I'm not saying that's cheap, because the most of the cost is in the coach.
Yeah, I guess my point is, it may be that as we move forward with these issues, we need to consider some things as realistic in the future that we may not have considered to be realistic in the past. And I guess I've just been so impressed by what happened in DPP that I'd hate to see us approach it from the standpoint of, well, that was a study and we had resources there that are not realistic for sort of day-to-day practice in our community.
Well, we're now, and we and a million other people are working on online, DVD, sort of more cost-effective approaches to this whole thing, which is important.
We have time for one more.
Okay, Bob Ross, Queen's University, Canada. I guess this is a question to you, John, because you and I don't disagree on these issues. I think it's one of perspective. As you know, I've thrown out the provocative idea that if we disassociated physical activity from weight loss, how would we be hurt? Because if someone engages in physical activity, they do it the way we'd like them to do, then eventually we're going to manage obesity. And the reason this is a thought point really, is because as you've alluded to a couple of times, and as we've seen and is in the literature, when people don't lose weight, they discontinue the behaviors. And this, I think, is a real tragic, is a truth. And I don't want to be overly dramatic and tragic. So what of the notion, the thought, to take away, I understand when you say weight, we don't want to dissociate obesity, it's part of the causal pathway. I accept that. But from a public health message, right, if we disassociate the two, how have we lost?
So I'll kind of say this easy. We looked at the when I've looked at Tim Church's data, we looked at our data, we looked at others, there's very few people who, over a BMI of 35, 40, 45, are physically fit and physically active at the level we want. And it's hard to get those people to do what we're talking about to get all the main health benefits. So I'm not saying where I think we lose is that for some people, the best pathway, and I'll go back to the physical therapy issue, some of the best pathway may be to start to induce some weight loss so that that person actually can do this without, oh, to hell with it. And that's where I think the public health is I'm not saying that a person with a BMI of 25 to 35 or so, but there are a lot of people out there who need to lose weight just to be functional. And I think if we disassociate it, we're actually doing those folks an injustice. So I think we have to send that message while saying we have people who can benefit significantly from physical activity and not dispel that. That's just my take.
Well, we're at halftime. We are going to take a recess until tomorrow morning. We'll have a hard start at 9 o'clock, focusing on innovative strategies across this country. Thank you all for being here today. Please join me in thanking this panel.